So we will be talking about the gestational diabetes mellitus today. This is a complete study guide to screening, diagnosis and management. It is based on the Delhi DFW SOP 2024 and national guidelines. So what will we cover today? So today we'll be covering definitions and epidemiology of GDM, maternal and fetal risk, screening and protocols, which is the DIPSI method, diagnostic criteria, which is DIPSI and IADPSG, medical nutritional therapy, physical activity guidelines, pharmacotherapy, metformin and insulin, management during labor and cesarean section, neonatal care in diabetic mother, referral criteria in each level of care, postpartum care and long-term follow-up, and contraception after GDM. So the first section is definition and epidemiology. So definition, gestational diabetes mellitus is hyperglycemia with blood glucose levels above normal but below diagnostic threshold for diabetes, first detected during pregnancy. ADA 2029 definition is diabetes diagnosed in the second or third trimester of pregnancy that was not clearly overt diabetes prior to gestation. Traditional definition is any degree of glucose intolerance with onset or first recognition during pregnancy. So key insight is GDM is diagnosed by screening, not symptoms. So GDM, the burden in India, this is important. Why GDM matters? So there is a 10 to 20% prevalence of GDM in India, which is higher than the global average. 40% lifetime risk of having type 2 GDM, type 2 DM after GDM. There's a 10% increased risk of metabolic syndrome and 2% increased risk of cardiovascular diseases later in life. So India has a very high genetic predisposition to type 2 DM, making GDM screening even more critical. As per HMIS data, neither universal 2-time screening nor detection of GDM is happening optimally across Delhi. Hence, that is why this SOP was released, because it aims to fix that. So now we'll talk about maternal and fetal risks. So maternal risks of GDM. The short-term risks are polyhydramnios, preeclampsia, hypertensive disorders, prolonged obstructive labor, increased risk of cesarean section, uterine atony, postpartum hemorrhage, recurrent infections, progression of retinopathy, diabetic ketoacidosis. Long-term type 2 diabetes mellitus, there's a 10% risk. Metabolic syndrome, there's a 30% risk. Cardiovascular disease, 2 times risk. GDM recurrence in next pregnancy, and offspring at a risk of GDM and type 2 DM. So the fetal risks are spontaneous abortion, intrauterine death or stillbirth, congenital malformations like cardiac or neural tube. This is not that much in GDM at least, but in overt diabetes mellitus, there is a higher risk of congenital malformations. Macrosomia, increased birth weight, shoulder dystocia, birth injuries, neonatal hypoglycemia, infant respiratory distress syndrome, polycythemia and hyperbilirubinemia, hypocalcemia and hypomagnesemia. So screening protocols, the DIPSI method, this is very important, not just from exam point of view, but also from clinical point of view. So who gets screened for GDM? In India, all women who come to your OPD for first ANC visit get screened. All pregnant women have to be screened for GDM regardless of age, parity, BMI or risk factors. There is no selective screening done under the Delhi DFW SOP 2024. Timing of screening is first visit any trimester, first test at first ANC visit. If she is screened negative at first test, then you have to do the second test within 24 to 28 weeks. If the first visit is after 28 weeks, then only one test is needed. If suppose she has come around 22 weeks, then the difference, as in the time difference between the two tests, need to be 4 weeks. So every secondary and tertiary first facility should have a dedicated DIPSI room within the ANC OPD for GDM screening. So what is a step-by-step procedure? You should greet the patient, complete the registration, explain the procedure, then dissolve 75 gram anhydrous glucose. Now this was something that was asked. What is the type of glucose? It is anhydrous glucose in 300 ml of clean water, can be given irrespective of fasting status or last meal time. Ask the woman to consume the glucose solution over 10 to 15 minutes, then direct her to the waiting area. Advise her not to eat or do any vigorous exercise during the 2-hour wait period. At 2 hours, collect capillary blood glucometer or venous sample, plasma calibrated GOD-POD method. Share glucometer result immediately, record in ANC register with contact details and next visit date. Now, a special situation. If she vomits within 30 minutes, reassure her, ask her to return the next day for a repeat test. Do not attempt to read the result. If a patient vomits after 30 minutes, reassure her, continue monitoring and collect the blood sample at the designated 2-hour mark as planned. Biomedical waste disposal, cotton swabs, yellow bin, blood strips and lancet, red bins, gloves, lead bin, red bin. Non-biodegradable paper, plastic, blue bins. Capillary blood sampling tips. Use distal site of fingertips. Avoid the little finger. Wipe away the first drop of blood with a clean gauze. Collect the second drop of blood on the glucose testing strip. Now, diagnostic criteria. DIPSI diagnostic criteria, interpretation 2 hours after 75 oral glucose load. Less than 140 is normal. Repeat at 24 to 28 weeks if tested in first trimester. If 140 to 199, gestational diabetes mellitus, start medical nutritional therapy, referral for management. Overt or pre-gestational may be type 1 or type 2. It can be diagnosed in pregnancy if fasting is more than 126 or random postprandial glucose is more than 200 at any time. Then we have the alternative IADPSG criteria, WHO 2013. Now it requires a fasting sample. What happened here? IADPSG requires a fasting sample at 1 hour and 2 hour. Any abnormal single value is GDM diagnosis. So fasting 8 hours overnight, normal threshold is less than 92 GDM if more than equal to 92. 1 hour post glucose less than 180 if it is more than equal to 180 GDM. 2 hours post glucose less than 153 if it is more than equal to 153, then it is GDM. So 75 anhydrous glucose load is given, fasting state is required, any single value more than equal to threshold is GDM. Then medical nutritional therapy. So medical nutritional therapy, all newly diagnosed GDM patients should be started on MNT first. Meal structure, you have to give them 3 main meals plus 2 to 3 snacks. Eat at consistent time daily. Carbohydrates 50 to 60% of total calories. Prefer complex, low GI carbs. Restrict rice, potato and juices. Then protein should be 10 to 20% of calories. 3 servings daily. Milk, egg, fish, pulses, nuts. Fats 25 to 30% of calories. Saturated fats less than 10%, cholesterol less than 300 mg per deciliter should be there. Fiber, high fiber diet delays gastric emptying, helps to control blood sugar. Hydration, water, buttermilk, soup. Avoid soda and fruit juices, unsweetened beverages only. Calorie requirement in GDM, base caloric requirement by activity level plus 350 kilocalorie per day in second plus third trimester. So sedentary, if she's sedentary, has a sedentary lifestyle, base requirement is 1900. If you add the 350, it becomes 250 kilocal per day. Moderate work, base requirement is 2230 kilocal, and in pregnancy you add 250. Now BMI based adjustment. Now if she is underweight, like less than 18.5, you add 500 kilocal per day based on the activity level. If normal, then no change. Overweight, she's 23 to 24.9, no change. Obese, you have to deduct 500 kilocal per day. So breakfast 10 to 20% meal distribution, lunch 20 to 30% of calories, dinner 30 to 40%, snacks up to 30%. What to avoid and what to prefer in food. Now fried food, you have sweets, mithai, or all of this, fruit juices and soda, white rice in large portions, potatoes especially fried, red meat and organ meat, refined cereals, high GI food. You have to prefer jawar, bajra, ragi. Now this might not seem very important from exam point of view, but I'm telling you from a clinical point of view, it will really help you, because you have to be, I know we can send the patient to dietitian, but if the patient has come to you, you also need to know what to give them and what not to give them, because not all patients might go to the dietitian, or not all patients, they'd like everything to be solved in one visit. And a lot of centers don't have dietitians, and what will you do? So this is very important to know. You should advise them to have jawar, bajra, ragi, whole grains and pulses, fresh seasonal fruits, green leafy vegetables, dal, curd, paneer, eggs, buttermilk and soup, baked, steamed food, high fiber food. Then physical activity in GDM. So benefits of exercise is that maternal, it minimizes the weight gain, improves glycemic control, prepares for labor, there is potential reduction in fetal adiposity. So type aerobic, walking, running, swimming, cycling. Intensity moderate, 60 to 90 APHRM. So they have to So RPE should be 12 to 14. Vigorous RPE is 14 to 16. So less than equal to 30 minutes continuously duration, and frequency no more than 2 consecutive days without exercise. Resistance 15, so resistance exercises like dumbbells, resistance band, pregnancy, pilates. Moderate should be 50% 1 RM. 50 to 10 exercises, 8 to 15 reps, 1 to 2 sets, 60 minutes, at least 2, ideally 3 times a week. Carbohydrate based snacks may be needed prior to exercise. Avoid high risk activities like contact sports, lying flat. Now let's talk about pharmacotherapy in GDM. When to start pharmacotherapy? Pharmacotherapy is started after 2 weeks of MNT. If we check the blood sugar, fasting, and 2-hour PPBS. So fasting, if it is more than 95 or 2-hour is more than 120, then pharmacotherapy must be initiated. In third trimester, we give them only 1 week of MNT plus exercise and check fasting and 2 hours. So second trimester, we give them 2 weeks of MNT. In third trimester, we give them 1 week. And if we check the fasting and postprandial 2-hour, and fasting is more than 95 and postprandial is more than 120, then we have to start them on pharmacotherapy. So early insulin without MNT trial indication. So preprandial glucose more than 110. 1 hour postprandial glucose more than 140. Then we can give them early insulin. GDM plus hypertensive disorder in pregnancy, FGR, macrosomia, polyhydramnios. Hyperglycemia diagnosed less than 20 weeks or more than 30 weeks on antenatal corticosteroids or in labor, or she has history of diabetic ketoacidosis. So we can give them insulin, which is drug of choice. Metformin also can be given, but there is a 26 to 50% metformin failure rate and may eventually need insulin. Metformin in GDM, so it is an insulin sensitizer. It inhibits gluconeogenesis, reduces glucose absorption, stimulates peripheral glucose uptake. So dosing protocol, we give them 500 mg OD for 1 week, and then we start them on 500 mg BD, maximum 2 gram per day. There can be abdominal pain, diarrhea, reduced with sustained release PrEP. So contraindication, hepatic dysfunction, renal dysfunction, cardiac dysfunction, hypertensive disorders of pregnancy, FGR, and high risk preterm birth. Advantage is that it is more convenient, less expensive than insulin, less monitoring is required, reduced neonatal hypoglycemia, improves compliance, useful in obese women, EU approved from preconception through pregnancy. Now caution, failure rate is 26 to 50%, so insulin is needed, associated with increased preterm labor risk. Do not prescribe if organ dysfunction is present. Report metformin use in HMIS, new element from April 2023. So insulin types and approved for pregnancy. So we have aspart, which is rapid acting. Onset is in 15 minutes. Peak is in 60 minutes. Duration is 3 to 5 hours. And it should be given at the start of each meal. Then we have lispro, which is rapid acting. Onset is 15 minutes, 60 minutes peak, and 3 to 5 hours duration. It should be given at the start of each meal. Then we have regular, which is short acting, 30 to 60 minutes onset, and peak is 2 to 4 hours. Duration is 6 to 8 hours. So it should be given 60 to 90 minutes before the meal. NPH is intermediate. Onset is in 2 hours. Peak comes in 4 to 6 hours. Duration is 12 to 20 hours. It should be given every 8 to 12 hours. Detemer is long acting. Onset is in 2 hours. And it never reaches a peak, so it has a duration of 24 hours. Every 24 hours it should be given. Then we have digludec, which is long acting, so its duration is for more than 24 hours, and dosing interval is also more than 24 hours. Why rapid acting aspart or lispro are preferred? Injected at meal start, not 30 to 60 minutes before. Peak matches post meal glucose, lowers hypoglycemia risk. Now basal insulin, NPH, detemer, degludec, these suppresses hepatic glucose output, maintains near normoglycemia in fasting state. It is safe in pregnancy. So what is the titration protocol? So blood glucose monitoring should be fasting, self-monitoring of blood glucose, fasting once daily after more than 8 hours of fasting. 2-hour postprandial 2 to 3 times daily after meals, or rotating. Paired post meal on different days. Like on one day they can do before breakfast, after breakfast. On other days they can do before lunch, after lunch, or on some days they can do before lunch, before dinner, after dinner. So initiating regular prandial insulin. So 2-hour postprandial is 120 to 150. You have to give them 2 units. If 2-hour postprandial is 150 to 180, you have to give them 3 units of regular insulin. 2R is 181 to 200, you have to give them 4 units of regular insulin. If you are initiating basal NPH at 10 pm, fasting insulin should be 95 to 120, 2 units NPH. Fasting 121 to 140, 3 units NPH. Fasting is 141 to 160, 4 units. Rule of thumb, for every 20 to 30 milligram in rise in blood sugar, add 1 unit of insulin. Titrate if only more than 20% values are deranged after 1 week. So recognition and management of hypoglycemia. Diagnosis is blood sugar less than 70. Any pregnant women on insulin can develop hypoglycemia at any point, so it is important to recognize, and treatment is essential. So symptoms will be tremors, sweating, palpitation, hunger, fatigue, headache, mood changes, tingling around the mouth. Severe can be confusion, abnormal behavior, visual disturbances, anxiety. Uncommon are seizures and loss of consciousness. So management is give 3 tablespoons of glucose powder in water. If no glucose, 6 tablespoons of sugar in water, juice or honey. Rest, avoid physical activity. After 15 minutes, eat a chapati with vegetable, rice, milk. If continuing, repeat glucose dose and weight. If more than 1 episode per day, consult the doctor immediately. More than 1 hypoglycemia episode per day, we have to refer to a district hospital. So management during labor. Timing of delivery in GDM. Now, induction of labor is at 38 to 39 weeks. Indian babies age earlier. Aging placenta increases stillbirth risk. If she is poorly controlled GDM or pre-gestational diabetes, 37 to 38 plus 6 weeks. If other comorbidities are present like abnormal fetal test, failed glycemic control, consider 34 to 36 plus 6 weeks. GDM plus macrosomia, effective fetal weight is more than 4 kg in diabetic, then elective LSAS at 39 weeks if fetopelvic disproportion is suspected. Previous macrosomic baby with poor outcome, elective LSAS. Intrapartum glycemic management. So glycemic targets during labor. You have to maintain a plasma glucose of 70 to 120 milligram per deciliter. Check glucometer every 1 to 2 hours in active labor. Check urinary ketones every 4 hours. So morning dose of insulin is withheld on the day of induction. Blood sugar level, if it is 90 to 120, then you don't add any insulin to 500 ml NS, and NS infusion rate is 100 ml per hour, that is 16 drops per minute. 120 to 140 milligram per deciliter, you add 4 units to the 500 ml NS, 100 ml infusion rate is 16 drops per minute. 140 to 180, it is 6 units you have to add, again the infusion rate is 16 drops per minute. If it is more than 180, then you add 8 units. If plasma glucose is less than 100, start 5% dextrose at 125 ml per hour, no insulin. Strict asepsis, restrict PV exams throughout labor. Management during cesarean, it has to be scheduled as the first case. Give usual dose of intermediate acting insulin on the night before surgery. Keep patient fasting after midnight. Morning insulin dose is withheld. If surgery is delayed, give basal insulin, that is 1/3 of morning NPH dose in 5% dextrose to avoid ketosis. Now check fasting plasma glucose and serum electrolytes in the morning. Prefer regional anesthesia. Awake patient allows earlier detection of hypoglycemia. Maintain a blood sugar of 70 to 100 milligram per deciliter during surgery with regular monitoring. Give prophylactic antibiotics 30 to 60 minutes before surgery. Strict post-operative plasma glucose monitoring. Early resumption of oral uptake. Pneumatic compression stockings plus early mobilization. It reduces thromboembolism risk. So neonatal care, baby of diabetic mother. So newborn management, so baby of diabetic mother, immediate care is routine neonatal care, skin to skin contact, early breastfeeding prevents neonatal hypoglycemia, comprehensive newborn examination. So neonatal blood glucose monitoring, at birth target should be 46 hours, target is always 40, but at 24 you have to check at birth 6 hours, 12 hours, 24 hours and 24 to 48 hours. At 24 to 48 hours, target is 50 to 60 milligram per deciliter. Signs of neonatal hypoglycemia, jitteriness, stupor, apathy, episodes of cyanosis, convulsions, apnea, spells or tachypnea, high-pitched cry or lethargy, difficulty feeding. Watch out for hyperbilirubinemia, hypocalcemia, hypomagnesemia, polycythemia, respiratory distress syndrome and birth asphyxia. So referral criteria at each level. So referral criteria, if she is a PHC and you have to refer to district hospital, it should be when FBS is more than 126 milligram per deciliter or RBS is more than 200. Fasting is more than 95 or 2 hour PPBS is more than 120 despite metformin insulin. Postprandial blood sugar is more than 200 at any time during management. Total insulin dose has exceeded 20 units per day. Coexisting medical obstetric comorbidities. Hypoglycemia more than once a day. Refusal to take insulin injection. If at a district hospital, when do you refer to a tertiary hospital? There is fetal growth restriction, polyhydramnios, macrosomia, recurrent hypoglycemia or decay, hypertensive disorders of pregnancy, organ dysfunction, liver, kidney, eye, heart, glucose not controlled despite 4 weeks on any regimen, overt or pregestational diabetes. Now, place of delivery decision guide. If she is well controlled GDM on MNT only, there is no macrosomia or complication, she can be treated at a district hospital. Well controlled GDM on metformin or insulin, no macrosomia or complication, EMOC or district hospital. If she is poorly controlled GDM, pre-gestational DM, or suspected macrosomia or preeclampsia, then tertiary care center with 24/7 LSCS facility. Fetal surveillance in GDM, 18 to 20 weeks you have to do an anomaly scan, 28 to 30 weeks growth scan, 34 to 36 weeks growth scan, biometry plus AFI, daily fetal assessment, 10 kicks within 2 hours, the Cardiff method. So postpartum care and long-term follow-up. So early breastfeeding has to be done. Initiate neonatal blood sugar monitoring at 1 hour, 6 hour, 12 hours, 24 hours, 48 hours. Prevents neonatal hypoglycemia. OGTT has to be done at 6 weeks, 75 glucose load. Fasting more than 126. She has to be diagnosed as diabetes. Postprandial 140 to 199. Intermediate glucose, like she has initial glucose, intermediate glucose tolerance. Postpartum more than 200, she is DM. Less than 140 is normal. Annual screening 75 gram OGTT yearly if 6-week test is normal. Counsel about 40% GDM recurrence risk. Lifestyle management, diet chart, exercise plan, weight reduction if overweight or obese, refer to NCD clinic if abnormal. Pre-pregnancy counseling, target fasting should be less than 100 mg per deciliter, postprandial less than 140 before next pregnancy, proper spacing between pregnancies. So future risk counseling, 40% GDM recurrence is there. There's a 10 times risk of type 2 DM, 30% metabolic syndrome risk and 2 times cardiovascular risk. So contraception after GDM. Contraception in women with history of GDM. History of GDM, no ongoing diabetes. All methods are MEC category 1, no restriction. IUCD, combined pills, progestin only pills, implants, injectables, barriers, all are acceptable. Non-vascular diabetes type 1 or type 2. So combined OC pills are MEC2. Progestin only injectables, implants, MEC2. LNG IUD MEC2, but copper IUD is MEC1, MEC1. So diabetes with organ damage, combined pills are MEC3 with caution or avoid. Progestin only, MEC2. Copper IUD MEC1, it is always safe. So MEC grading you should know. 1 is no restriction, 2 you can generally use, 3 is caution with backup available, 4 is do not use. Preferred choice after GDM is IUCD, copper or LNG, and barrier methods are the safest first choice for women with GDM history or active diabetes. So quick summary. Screening all pregnant women, DIPSI 75 gram, 2 hour post glucose, fasting or non-fasting. Over DM 2 hour more than 200. Start drugs fasting more than 95 or 2 hour PPBS more than 120 after MNT. Labor target is 70 to 120. Check 1 to 2 hourly. Delivery if uncontrolled, tertiary center, individualized based on comorbidities. Contraception, all methods MEC1. IUCD is preferred. If GDM diagnosis, 2 hour, GDM diagnosis is when 2 hour post glucose more than 140. MNT trial, second trimester is given for 2 weeks, third trimester for 1 week. Drug choice, insulin is preferred or metformin is an alternative. Delivery, if it is controlled, 38 to 39 weeks. Postpartum, OGTT at 6 weeks, then annual. Lifestyle modification. At HMIS, you have to report OGTT, GDM plus, insulin or metformin 1.5. These are all the guidelines in the HMIS. So thank you. Key takeaways from all of this is that GDM can affect all pregnant women. So universal screening is mandatory under DIPSI protocol. DIPSI test 75 gram glucose, 2 hour reading, non-fasting, as in she does not require to be fasting for this test. If it is more than 140 2 hour reading, she is GDM. First line medical nutritional therapy plus exercise, 2 weeks in second trimester, 1 week in third trimester. and then pharmacotherapy if the fasting and PPBS meets the threshold. Insulin is the preferred drug. Metformin is safer alternative. Maintain glucose 70 to 120 milligram per deciliter during labor. OGTT 6 weeks postpartum plus annual screening after that. Long-term GDM women are 10 times risk of type 2 DM, and lifestyle modification is crucial. So thank you for watching this. I'll see you in the next video on the next lecture on the next guideline. If you have any particular guideline you want me to talk about, do mention it in the comments. So thank you, and I'll see you in the next video.